I started this meeting or this symposium about 4 years ago, pre-pandemic, for multiple reasons. Number one, I was going to all of the major national and regional meetings, and every meeting I would hear multiple papers saying, women do worse, African Americans do worse, next paper, repeat. So we would hear the same mantra over again that we acknowledge we have a problem with our patients, and yet we weren't going anywhere. This was repetitive year after year, and I thought it's time that we need a venue where we can dive deeper into what the problem is, and better yet, what can we do to change the outcome so that the answer is not women do worse, blacks do worse, etc. The second purpose for it is to facilitate progress for the generations behind me. When I started, I'd walk into a room at major meetings, there would be 2 or 3 other women and hundreds of men. The opportunity for advancement was more difficult. We're trying to make it not so women jump over men, but that women have equal opportunity. Part of the problem is women haven't always been given opportunities. 99% of the time, it's unconscious bias. It's not that our male colleagues are trying to put us down, but they just don't always think of offering the opportunity of, you might be good for this position, or would you like to be a PI, or would you like to be on a committee? And another part of it is also intrinsic to many of the women, that the way we're conditioned as we grow up, and this has been shown again in business, is that women often don't feel that they're prepared for a position, even when they're more qualified than their male colleagues who will say they are prepared for the position. So we don't have people sponsoring us for positions, and we don't self-nominate. That's part of the issue. One of the problems is, when the books were written, the patients were considered to be white males, because we assumed that women didn't have cardiovascular disease. Women didn't get chest pain, women didn't get peripheral arterial disease or aneurysms. We know that's not true. But the symptomatology, the way it's written, is written for white males. So when women present, they often have atypical symptoms. They're really not atypical symptoms. As one of my friends said, they're really women's symptoms. So for example, with stroke, women are much more likely to have a headache along with the classic symptoms, or have some cognitive changes. So they may, first of all, assume that it's just a migraine, not self-present, or when they come to the emergency room or call their primary care physician, that individual may also make that assumption, and so they don't get fast-tracked for the same stroke workup that your male friends would. Similarly with peripheral arterial disease, women present differently. One of the biggest things women do is they slow their walking pace. So they won't say, no, I can't walk a block. They just take 3 times as long to walk the block. Yet when their study is done, what it shows is that women are more physically disabled. Their claudication distance, their walking time, all those are more impacted than men. Yet men complain more of pain, and therefore men have more interventions than women, and women end up being diagnosed as being asymptomatic or coming in with chronic limb-threatening ischemia when they're more frail. I belong to multiple major organizations. I believe in all the meetings, VEITH, VM, the regionals, absolutely. The problem is they're all very overburdened with multiple things that they're trying to accomplish. There is not the time during those meetings to really delve deeper into what the issues are. We used to have time periods for women's get-togethers, but even when we have them, if we have 2 hours, we're lucky. That's not enough time. If we continue doing that, we won't make progress. We're doing a day and a half, and we've limited it to a day and a half because women also tend to have younger families when they're early in practice. There's some other social issues, and we don't want people to feel guilted that they can't come to the meetings. But we've limited it to a day and a half where we go through a high intensity of the women's vascular health issues, as well as women's leadership and growth and promotion issues as well. We need that time in a focused environment where we can really deal with it. If we wait for it to happen at the national and regional meetings, it will never happen. We will continue hearing women do worse, blacks do worse, next paper. And we need to go better than that. There are multiple issues. So first of all, there aren't as many of us that are in senior level. So we don't expect that just because we're women, we should be given a senior position. That's not what we're saying. But women need to be given the opportunity at every stage so that if they are capable, then they should be given the leadership roles. So again, it's not jumping a person over. We're looking to really have equity and diversity, but people have to be given the option. So it's been demonstrated in multiple areas that women in medicine, they may start as assistant professor at the same level, but fewer of them get to associate, and fewer even get to professor, fewer get to chief of division or chair of department. Now, not every woman's going to aspire to that. That's totally fine. We're not trying to make every woman become a department chair or a division chief. It really is enabling women to do what they want to do so that they have equal chances as their male colleagues. Some of it is appropriate sponsorship and mentorship. Some of it is work-life balance. There are a whole host of issues, but there have been a few universities that have really targeted this, and they've shown by targeting women and minorities, they can actually have women and minorities advance and have a more diverse leadership and more diverse hierarchy than what most of us have. So it has to be a conscious, intentional effort. You can't just say, we want to be diverse, okay, let's move on. And that's what many organizations do. We have to make conscious efforts to empower and enable people to be successful. So just naming a person assistant professor and saying, okay, you can have some lab time, doesn't necessarily set them up for success. Do they have the right mentors? Do they have the right partners? Are we giving them the opportunities to come to a major meeting and present? Are we suggesting their names? What are we doing to help? So it isn't a simple answer, but working together, we can accomplish a lot of great things. We would love to see all of you at the meeting. It's April 28th and 29th, so it's an all-day Friday, half-day Saturday in Buffalo, New York. Next year, we're likely to move to Chicago to try to see if we can have even more people come if it's easier to get there. We bring the trainees in without cost to the trainees when we can so that they're able to attend. We want all the women, and we also want men who are interested in helping their partners, their peers, their trainees to come as well.